In this topic, we're going to be discussing polyhydramnions and oligohydramnions. I'm Dr. Mrs. Temitope Okunola from the Department of Obstetrics and Gynecology, Ekiti State University. I'm also a consultant gynecologist with Ekiti State University Teaching Hospital, Ado Ekiti. We're going to be discussing this topic under the following outline. We'll talk about the learning objectives, introduction, physiology of amniotic fluid, etiology, history taking, examination, investigations, treatment, complications, practice, and references. Learning objectives. You must be able to diagnose polyhydramnions and oligohydramnions. Also, you must be able to manage patients with these conditions, with polyhydramnions and oligohydramnions, and you must be able to prevent the complications of polyhydramnions and oligohydramnions. Introduction. What is polyhydramnions? It refers to excess accumulation of amniotic fluid. It is defined as amniotic fluid by amniotic fluid index about 95th centile of gestational age. It's found in 1 to 2% of all pregnancies. Oligohydramnions refers to a low level of amniotic fluid in pregnancy. It is defined by amniotic fluid index that is below 5th centile for the gestational age, and it is found in about 11% of all pregnancy. From these definitions, you can see that oligohydramnions and polyhydramnions are at the other end of a normal spectrum. Polyhydramnions is defined when it is above 95th centile, while oligohydramnions occurs when it is below 5th centile. In other words, we say polyhydramnions is when the liquor is too much, while oligohydramnions is when the liquor is too little. Amniotic fluid production. Physiology of amniotic fluid. How do we get to the amniotic fluid? Amniotic fluid is produced from transudate of fetal serum from fetal skin and umbilical cord by 10th week. Initially, it's just the transudate from the amnion. But by the 10th week, the transudate of fetal serum is from the transudate of fetal serum and from fetal skin. However, by the 16th week, the fetal urine will have taken over of production of amniotic fluid. So by 16th week, amniotic fluid is mainly produced from fetal urine and the lung fluids. Whereas now, that is production. We're talking about amniotic fluid removal now. Is basically by fetal swallowing. So the liquor volume is a balance between the amniotic fluid production and amniotic fluid removal. So amniotic fluid basically from 16th week upwards, amniotic fluid is being produced by fetal urine and lungs and lung fluids, while it's being removed by fetal swallow. So it's the critical balance between the two. That's what forms the volume of the amniotic fluid. The volume of amniotic fluid increases, the amniotic fluid volume increases at 10 mils per week as week 8, and it becomes like 60 mils per week by week 27, by week 21. The volume per week. Around week 10 is about 30 mils. Around week 20 is about 300 mils. Week 30, 600 mils. Week 38, that is at term, liquor volume should be around 1,000 mils. While at week 40, it becomes 800 mils and 42, 350 mils. You will discover that after term, this liquor volume reduces gradually. Functions of amniotic fluid. Why does the fetus need amniotic fluid? It protects the fetus from mechanical injury. It permits movement of fetus while preventing limb contraction. It prevents adhesions between the fetus and the amnion, that is the membrane. That is the membrane, fetal membranes. Then it promotes fetal lung development, alternating egress and retention of lung fluids by fetal breathing movements. It maintains the temperature. Injection of amniotic fluid promotes growth and development of the gastrointestinal system, and also it's been found to have minimal nutritive function. Etiology. What the etiology of these conditions? Etiology of polyhydramnions. fetal malformations, anencephaly, duodenal atresia, esophageal atresia. A good way to remember this etiology is to remember that amniotic fluid is being removed by fetal swallowing. So anything that prevents fetal swallowing will lead to accumulation of amniotic fluid, thereby leading to polyhydramnios. You discover that in all these conditions, anencephaly, duodenal atresia, esophageal atresia, anything that will prevent fetal swallowing will lead to excessive accumulation of amniotic fluid, thereby leading to polyhydramnios. Genetic anomalies, the trisomies like trisomy 21, trisomy 18, they have been found to lead to polyhydramnios. Also, maternal diabetes mellitus is associated with polyhydramnios. Multiple pregnancies, fetal-fetal transfusion, when we have fetal-fetal transfusion, where one twin we will have polyhydramnios and the other twin will have oligohydramnios. Fetal anemia, resource immunization, as is also associated with polyhydramnios. Also, virus infections, touches infections, like rubella, cytomegalovirus, parvovirus, B19. Also, macrosomia, as we found to be associated with polyhydramnios. Etiology of oligohydramnios, pre-labor rupture of membranes. When a woman presents with oligohydramnios, the first thing to rule out is whether the membranes have ruptured or not. Because once the membrane is ruptured, the amniotic fluid will leak, and that will lead to the reduction in the amniotic fluid volume. Another important etiology of oligohydramnios is placenta insufficiency, renal agenesis and dysplasia. This is another fetal anomaly. We said mainly by 16th week upward, the liquor volume, the amniotic fluid is being produced basically from fetal urine. So when there is defective production of urine by the fetus, by renal malformations like polycystic kidneys, renal agenesis or renal dysplasia, then there will be oligohydramnios because there will be reduced production. Also, obstructive uropathy. The fetus is producing urine, but the urine cannot be, there is obstruction to the urine being produced. Also, genetic or chromosomal abnormalities like trisomies. Trisomies are also associated with oligohydramnios. Viral infections like touches infection, that's like what we said earlier. Then post-date pregnancy. That's another important and common cause of oligohydramnios. History. How do you manage? Now you've diagnosed oligohydramnios or polyhydramnios. How do you manage? History taking. In polyhydramnios, the symptoms that the woman may present with shortness of breath from distended abdomen. Also, the woman might start having preterm contractions. The woman may have respiratory distress or maternal discomfort. Oligohydramnios, this history taking, there may be history of leakage of fluid, just like what I said earlier on, that pre-labor rupture of membranes is a common cause of oligohydramnios. So the first thing you must ask from the patient whether she has ruptured her membranes or not, any history of wetness or dampness, then any history of decreasing fetal movement. Probably she has noticed that the baby is no longer moving as the baby used to do. Examination. Symphysofungal height and gestational age disparity. Most of the time, this is what the clinician will first notice. And you start thinking whether there is oligohydramnios or polyhydramnios. For example, when a woman's gestational age by calculation by date or by ultrasound is 33 weeks, and you are measuring a symphysofungal height of 38 weeks, and you have palpated, you are sure this is a singleton fetus, the next thing you start thinking of is polyhydramnios. Also, on the other way around, peradventure the gestational age is 38 weeks and the symphysofungal height is 34 weeks. You start wondering, small for day uterus, what are the causes? An important cause of small for day uterus is oligohydramnios. So you start thinking on that side too. Then abnormal fetal presentation. Abnormal fetal presentation. Polyhydramnios can lead to abnormal fetal presentation or unstable lie. the baby will just, because there is space, there is so much fluid, the baby will just be moving from one line to another, maybe transverse, maybe oblique, maybe cephalic. The next time you are seeing the woman, you discover that this is now breech because of polyhydramnion. Start thinking probably that lack of volume is much. Then on examination, when a woman is present, you can do a sterile specular examination if you are suspecting labor rupture of membranes. Investigations. So what do you do? Once you suspect as a clinician, you think this is polyhydramnion or this is oligohydramnion, what do you do? You have to do an ultrasound. Ultrasound is the mainstay of diagnosis. You measure the amniotic fluid index on ultrasound. The normal is 5 to 25 centimeters. So when the amniotic fluid index is less than 5, you know that is oligohydramnion. And when it is more than 25 centimeters, that is polyhydramnion. Another way you can use, another criterion you can use to measure, to diagnose oligohydramnion or polyhydramnion on ultrasound is using a single vertical pool. The depth of a single vertical pool that is cord-free. The normal should be between 2 to 7 centimeters. When it's less than 2 centimeters, that is oligohydramnion, and when it is more than 7 centimeters, that is polyhydramnion. What other things that you need to do on ultrasound apart from measuring the Lycor volume? The fetal biometry, because there are some other things that are associated with these conditions. For example, a fetus with intrauterine growth restriction may present with oligohydramnion, so you need to measure the fetal biometry. A macrosomic fetus also may present with oligohydramnion. You need to measure the fetal biometry. Estimated fetal weight, you need to measure the estimated fetal weight. Then, when you, for example, in cases of intrauterine growth restriction, you may need to do umbilical artery Doppler. You may need to do fetal anatomy when you are considering fetal anomalies. So you may need to do an anomaly scan. Then, middle cerebral artery, peak systolic velocity, for example, in resus isoimmunization. Non-stress test, cardiotocograph. Also, in ultrasound, when you do ultrasound, you need to do a fetal biopsychal profile. Amniotic fluid volume is part of fetal biopsychal profile, so you can just do everything together so that you will be sure of you know the fetal well-being. Then, non-stress test, cardiotocograph, is also a part of the fetal biopsychal profile that you may have to do. Karyotype, yes, when you're suspecting trisomy 13, trisomy 18, you may need to do a karyotype. Oral glucose tolerance test, that's for when your suspicion is diabetes mellitus. Then you might have to do a fetal MRI for fetal anomalies like tracheoesophageal fistula or esophageal atresia. Maternal infection screening, when you're suspecting touches infection, and maternal blood group, resus group, or indirect blood group, indirect Coombs test when you're thinking about resus isoimmunization. Treatment of polyhydramnion. Polyhydramnion most often time gives the woman discomfort because of overdistension. So what we need to do is to reduce amniotic volume to improve the maternal well-being and prolong pregnancy. Because if you don't improve the maternal well-being by relieving the woman of that discomfort, eventually the woman may start having preterm contractions and may start having preterm contractions, which may lead to labor rupture of membrane, and eventually lead to preterm delivery. So because of this, we want to reduce the amniotic fluid volume. Amnio reduction should be done. It has a clear clinical benefit. One, you relieve the woman of the abdominal discomfort. Some of the women present with respiratory distress. You also relieve the woman of the distress from the discomfort, and you'll be able to prolong the pregnancy. So, amnio reduction has a clear clinical benefit, and this should be done under ultrasound guidance and monitoring. When you're doing amnio reduction, you should aim at amniotic fluid index of 15 to 20 centimeters. When you get something around that range, you can leave. You can end the procedure and repeat the procedure later if you need it, if it's necessary. I can remember that a patient that we managed with twin pregnancy with polyhydramnions. Yes, twin pregnancy with polyhydramnions. We had to do amnio reduction under ultrasound guidance 3 times in the course of 3 weeks, and we were able to prolong that pregnancy for 3 weeks. That's a lot. By the time you're moving a pregnancy from like 31 weeks to 34 weeks, I think we admitted at 31 weeks and she eventually had to deliver at 34 weeks. That's a lot. So it has a clear clinical benefit. Another thing we can use to reduce the liquor volume is prostaglandin synthetase inhibitors like indomethacin, solindac. They lead to vasopressin-induced antidiuresis, leading to reduced fetal urine production. However, it has a side effect, premature closure of fetal ductal atterosus. So when you're giving these drugs, you need to monitor the blood flow through the fetal ductal atterosus. You need to monitor the blood flow. Investigative therapies. The therapies that are not yet proven, but they are still under investigations. They are being developed. Intraamniotic administration of vasopressin is one of the investigative therapies. Then, after reducing the amniotic volume, you optimize the timing of delivery. Just like what I said, that we admitted a woman with twin pregnancy and polyhydramnions at EG of 31 weeks. We were able to prolong the pregnancy to 34 weeks. Yes, just to optimize the timing of the delivery in severe maternal discomfort, and you prevent, or you have to deliver when there is severe maternal discomfort or there are obstetric complications. Treatment for oligohydramnions. You need to treat the underlying cause. One important cause of oligohydramnions is intrauterine growth restriction. So once you get the cause, look for how to treat it. For example, you look for the cause of intrauterine growth restriction and treat appropriately. Also, after treating, you need to optimize the time of delivery. You can't just wait until when the woman falls into labor in a woman with oligohydramnions. Then, temporary steps that we can take to correct oligohydramnions. Oral intake of fluids or intravenous fluids as we found to temporarily, just temporarily, to increase the liquor volume. Then, amnio infusion during labor. Infusion of saline solution to reduce the risk of umbilical cord compression, because umbilical cord compression is one of the complications of oligohydramnions. So, amnio infusion during labor, just to prevent umbilical cord compression. Also, investigation therapies that are still under investigation, that are still being developed. Tissue sealants, then combination of hydration and desmopressin. Complications. What are the complications of polyhydramnions? Just like we have said earlier, it can lead to preterm delivery. It can lead to a miscarriage or a stillbirth. It leads to maternal dyspnea. The woman will not be able to breathe very well. It can lead to pre-labor rupture of membrane from over-distension of the uterus. Also, umbilical cord prolapse. When there is over-distension, when there is polyhydramnions, there is over-distension of uterus, there can be pre-labor rupture of membrane and the umbilical cord can prolapse. It can also lead to intrauterine fetal death, and it can lead to postpartum hemorrhage after delivery because that uterus is over-distended. So over-distension of uterus, like polyhydramnions and twin pregnancy, are risk factors for uterine atony, which is the commonest cause of postpartum hemorrhage. Complications of oligohydramnions. Just like for polyhydramnions, it can also lead to miscarriages and stillbirths. It can lead to premature births because you may need to deliver early. Then fetal distress, especially during labor, due from umbilical cord compression, can lead to perinatal asphyxia. Once the baby is delivered, there may be perinatal asphyxia or hypoxic ischemic encephalopathy. Also, it can also lead to cord compression. Due to oligohydramnions, can lead to cord compression. It can also be found to be a cause of cerebral palsy or meconium aspiration, especially in postdated and postterm pregnancies. Practice. Now, this is a long essay. A 24-year-old unbooked gravido 2, para 1 alive, with ultrasound diagnosed oligohydramnions at estimated gestational age of 42 weeks, presented at the emergency room. What are the likely complications and how will you prevent them? To answer this question, as a form of introduction, you must first state the obvious cause of oligohydramnions. With this case scenario, the obvious cause of oligohydramnion is postpartum pregnancy. Just like what we discussed when we were talking about the physiology of amniotic fluid. We said by 42 weeks, we expect the average life to be like 350 mils. So it has reduced. You can compare 350 mils to 1 liter at 38 weeks. So it will have reduced. So that is the obvious cause of oligohydramnion in this patient. So then you will not state the likely complications. Mention them because there will be marked for stating it. The question says what are the likely complications. So you must state the likely complications. Then how to prevent the complications. Now prevention of the complication is just basically appropriate management. It's just asking you how will you manage. That's what to do to present a complication. So you start from history taking. This is an unknown woman. She's just coming for the first time. You're seeing her at the emergency room at 42 weeks. So you need to take a holistic approach. Take proper history, where she's had antenatal care, what has happened during the antenatal care, the drugs she has taken. Take good history of this woman. Know where she's coming from, what has she done, so that you first establish why did the pregnancy have to go up to 42 weeks. There could just be wrong dating. It may be that the date is wrong or something. Ask for earlier ultrasound to date this pregnancy. So when you take appropriate history, you examine the woman. And from your examination, it is very important for you to know, to check the fetal heart rate. You need to know whether that baby, whether that fetal heart rate is there present or not. Then investigations that you will do. You have to repeat that ultrasound and confirm oligohydramnion yourself. So you do an ultrasound to confirm oligohydramnion. You check the fetal biometry. It could actually, this baby can have intrauterine growth restriction with oligohydramnion. As in, the baby can have other causes of oligohydramnion apart from postpartum pregnancy. There could be renal anomalies, there could be renal dysgenesis, there could be polycystic kidneys in the fetus. So you have to take holistic approach, put a good history. Then the ultrasound should include fetal biophysical profile. Those are the investigations towards your line of thinking. Then treatment. How will you treat this woman? The treatment at this stage is delivery. The pregnancy is already 42 weeks. Postpartum pregnancy, delivery. How do you deliver this woman? This is a woman with oligohydramnion. She has oligohydramnion, and the pregnancy has gone to 42 weeks. So how do you deliver this woman? After evaluating this woman and looking at the woman, taking an holistic approach. This woman is at risk of cord compression. She's at risk of meconium aspiration. The fetus is at risk of meconium. Baby is at risk of meconium aspiration syndrome. A lot of complications. Then, if you want to go through the line of having a vaginal delivery, do you have the facilities to monitor this baby? Do you have a cardiotograph to continuous electronic fetal monitoring for this baby? Even with continuous electronic fetal monitoring for this baby in labor, after delivery, the baby can still have meconium aspiration syndrome. So the best route of delivery for this woman would be to have a cesarean section, so as to prevent all these complications. She's already at risk of this complication, but at least to minimize the risk so that the obstetrician will not add. As a doctor, you will not be found wanting of doing something you're not supposed to do. The best line of management the best route of delivery for this woman at this 42 weeks. Then you conclude that after doing all this, taking this history and examination and delivery by cesarean section, you will have been able to prevent the complications. These are the references. Thank you.